Good evening, and thank you for joining us for the patient education series of 2022 of the Comprehensive MS Center. Tonight, our topic is Black Americans and Multiple Sclerosis Update 2022. I'm happy that Dr. Okai has found time to join us tonight and present. And without further ado, I would like to invite Dr. Okai to take us through the first part of our presentation this evening. Dr. Okai, please take it from here.
Thank you, Dr. Lice. It's a pleasure to be back for another year of this talk, and I'm happy to be presenting on this important topic. So like you heard earlier, we're talking about MS in Black Americans. And so I want to start off by first talking about who has MS. All right, in the United States, we have almost 1 million people that have been identified with having MS. And we know what we know now is that women are more likely to be diagnosed with MS compared to men. And when you break that down, there is an increased preponderance of female Black women being diagnosed over time. We also know that Black Americans are at a greater risk of developing MS compared to Native Africans. And this is important because the ancestry of Black Americans we know go back to Africa. So why is this? And that's a question that needs to be addressed. All right, and next is that several studies have shown a slightly lower risk and higher risk for MS for Black American women compared to white women over time. So all of these observations and studies have pointed to an increased incidence in Black Americans. Moving on, let's talk a little bit about individually. So we talk about the population level. Let's look individually at in MS patients. So what we know about MS patient is that 15% of them have a relative with MS. And MS can occur at any age, but mainly we find the diagnosis occurring between the ages of 20 and 40 years old. Blacks have been noticed to be diagnosed at a younger age compared to their white counterparts. So women, for example, Black women are diagnosed at a median age at 35.4 years versus 37 years for white women. And then men at 33 years compared to 37 years for white men, sorry. So we have a high proportion of Blacks being diagnosed before the age of 30. And this is important because in the 20s is when people are starting careers, it's when they're starting life. And when you are diagnosed with debilitating disease, potentially debilitating disease, this can change the course of your life over time. Now we talk about the individual, let's talk about family studies in MS. What we found out is most people tend to ask when they come into the clinic, what is the likelihood that my child will have MS or another family member, or I have a family member with MS, what are the chances of this occurring? We do know that MS is not passed down through the family lineage in a top-down fashion, meaning that it's not a gene that goes from parent to child and so on. what happens is that there is this pool in people, the tendency to develop autoimmune diseases can occur at different rates. So the highest rate that we have seen MS being diagnosed is in identical twins. Overall, the risk, as I said on the previous slide, is 15% in the family member. But in identical twins, we see that the highest incidence is 25 to 35% over time. Non-identical twin carry the almost similar risk as just siblings or other family member, which is 3 to 4.5%. And if you have a parent with MS, your risk is 2 to 3% over time. Moving on, continuing about who has MS, an estimated number, as I said in the first slide, of people of an estimated number of individuals in the US is about 900 to 1 million. So that makes it about 363 cases per 100,000. I'm putting up a study where veterans were observed between the 1900s and 2000. And when we break down the demographics in here, we see that the MS cases in the Department of Defense are very significant, but the average incidence range from 27 to 26 incidents per 100,000. And that is a significant, but breaking it down between white males, white females, Black males, and Black females, we see that overall, whichever way you look at the data, the incidence is still higher for Black women compared to the white female counterpart. So what does this tell us? Well, this is a Department of Defense study over time. In the US, we do not have a centralized system that we can look at data and really collate it. It's so disjointed. It varies from state to state, and it also varies from institution to institution. And this leads to disjointed data, and we do not get an accurate percentage over time. So this really underscores the need for a national registry per se that can look at neurological condition and survey and see how it's occurring, the incidence, the prevalence in population over time. New York State have a consortium where physicians contribute to that and contribute information over time. And when we look at the New York State MS Consortium, we see that there's no difference seen in the type of MS over time. And MS patients with relatives were diagnosed similarly with Black Americans and not Black Americans. So when you look at Black Americans, you have a 16.7% for Black Americans, and those who aren't Black, 19.2%. What was interesting in this study is that Medicaid, so state Medicaid as the primary insurance, was higher for Black Americans compared to their non-Black counterpart, and Blacks were at a higher risk of requiring the use of a cane. Now, when you start using the cane, your independence is affected, and that can also lead to dependence on things and take away your livelihood sometimes. So does that mean that this is the reason why we see a higher number of Blacks on Medicare, because they're disabled early and they lost income and require state insurance to continue their health care? That's something that still needs to address, but that's what the trend looks like over here and sometimes throughout the nation. So this is just a graph that we use in clinical practice, that clinical and research for MS, and it shows that for someone with MS who is not limited functionally, especially mobility-wise, they're able to do everything that they want to do, run and play sports and everything else. And as the disease progresses, they start to have fatigue and then use of cane, walker, and bedridden. And we see that the Black patients in this group have a earlier time to the cane compared to the non-white counterpart. So when does MS start overall? Well, it's hard to pinpoint unless someone presents with a very significant event over time. But when we look at different databases over time, we see that people who are diagnosed with MS, 5 years prior to that diagnosis, they have had some contact with the healthcare system. They've either had a hospitalization, seeing the doctor for something, and are more likely to fill a prescription. What we've also seen as well is that neurofilament light chains level, and that is something that will be discussed later on, but it's a marker in the blood of MS patients, increase 6 years before the clinical onsets of MS in patients. And then we have Epstein-Barr virus, and this has been in the news recently. Epstein-Barr virus, the antibody titers in MS patient increase several years before clinical onset of MS in patients. So there are other factors, especially environmental ones, that increases the risk of MS. And what we know for certain is that people who are smokers have a higher risk of developing multiple sclerosis over time. And the latest study is that nearly all MS patients with Epstein-Barr have Epstein-Barr virus positivity versus those who do not have MS over time. And what we have known for a while over time is that vitamin D levels have a protective effect and lower the risk of MS, of developing MS over time. So the next slide, I'm going to delve a little bit deeper into Epstein-Barr virus and what is it and what we know about it. So it's a very common virus. Almost 95% of patients have the virus, and it can cause infectious mononucleosis. Mono is, as it is commonly known, or for a teenager, it's called the kissing disease. So that is what Epstein-Barr virus causes. And after the infection, it causes fatigue in most people, but after you recover from the infection, the virus is still in the body and it stays there, it's still silent over time. And we know that Epstein-Barr virus have been linked to different type of cancers and different type of autoimmune disorders. So how does this relate to MS over time? Well, 99% of people with MS have antibodies against Epstein-Barr virus. Well, what does that mean? Well, so this was studied over time in the military, and they look at almost 1,000 individuals who developed MS after enlistment in the US military. and blood samples were obtained from them. And once again, you see the phrase neurofilament light chain, or NFL, over time. So what NFL is what we call a biomarker, and we think this is a possible marker for MS. But these samples were assessed in 25 of the cases of people who developed MS. I must point out here that most of the patients in this study were male, and most of them were less than 20 years of age at the time their blood was first collected. And what they found out was that of the people that developed, the 800 who enlisted, almost 99.9%, so 800 out of 801 people enlisted men develop antibodies to Epstein-Barr virus. And the risk of MS increased after the infection with EBV, and compared to another common virus, CMV, that was not seen. And there was a delay of about 10 years between when the presence of Epstein-Barr was seen and the onset of MS. And in those who develop MS, NFL, or serum neurofilament light chain, only increased after the infection. So EBV could be a risk factor for MS, but it's important to point out that it is not the cause of MS. The next slide, I'm going to talk about serum neurofilament light chain of NFL. I've used this in the past several slides, so let me go a little bit more into it and talk about it. So this is a very busy slide, and I'm just going to do a quick overview of it. But neurofilament is found in the neurons of everyone, and it is there to help support the neuron over time. So you have the heavy chain, the light chain, and the medium chain. Well, if there is damage to your nerve, then that support that the nerve has from the neurofilament chain is affected. And when the damage occurs, the neurofilament is dispersed into the serum and the CSF. And this is what we are measuring over time to see if there is an increase. Is that a marker of damage to the neuron, or is it something else? But what we have seen is that it indicates that the neuron has been damaged and that support system is not intact anymore. All right, so I also mentioned the word biomarker as I've been talking. And what exactly is a biomarker? A biomarker is a substance that we can use to indicate what is going on in the body at that time, so a biological state. We want markers that we can test and make the diagnosis. And as we know right now, there isn't a single blood test that help us make the diagnosis of MS. But if we have a biomarker, we want it to be very sensitive and very specific. So what does that mean is that if that biomarker is present, the likelihood of developing MS, we can say with some certainty, is over 95% or more. And it's very sensitive. So it's sensitive to the disease, and it's not associated with a whole lot of other diseases that it can be mistaken for. And also it should be accurate and help prognose the outcome of whatever treatment we are giving the patient. Then we also would like to see a biomarker for screening. So we don't want false positive or false negative tests. And we don't want the acquisition of the biomarkers to be complicated. It should be something very simple, like a blood draw that patients can go get it done, and we can get an answer right away. And so blood or urine is something that's very simple, as opposed to doing a spinal tap. So, and it should also clearly reflect what stage of the disease the person is in. You know, it's in relapsing versus progressive versus secondary progressive. This is a debate that MS providers have over time regarding secondary progressive but still relapsing phases of MS. So what is the wish list we have for MS when it comes for biomarkers for MS? We want one that would aid in diagnosis. So in addition to MRI, we want a marker that will also give us some certainty that the diagnosis of MS we're making is very highly specific. We want one that helps us differentiate between the different forms of MS. We want one that helps us make a prognosis of what the patient is going to look like over time. And then one that outside of MRI, we want one that will also help us determine if there is a response to treatment and how the disease progresses. So you notice here that we have MRI over time. MRI has been a great tool for MS. It makes the diagnosis easier and faster, but there are some shortcomings to this.